Yeah, so I'm a doctor in intensive care. I trained in anesthetics. So that's about 15 years, 10 years post medical school. I hear most of you guys are sort of year 12, year 13 applying for medicine. It's a fantastic time to be. Medicine is a great job. Strongly encourage any of you to think about doing it, and we'll talk through one of the specialty options that it's available to you. So we're going to look at what ITU is and what it offers to patients. Most of our talk will be about the ethics of ITU because I think it's a really interesting area to practice medicine. And then we'll do a bit on the ITU day and how that might change as you progress through your training. And then just as a bit of fun at the end, we'll do a medical top trumps and we'll compare ITU to some of the other specialties that might be available to you once you've got your medical qualifications in term. So ITU, in the intensive therapy unit. It's also called sometimes in the intensive therapy unit, intensive care unit, critical care unit. Those are all pretty much the same. Um, uh, and it's an inpatient space. It looks like any other part of the hospital. What sets it apart is that we've got an exceptionally high nurse ratio. So we have either 2 to 1, two nurses to every patient, sorry, one nurse to every two patients or one nurse to every patient, which is way, way higher than the rest of the hospital. And that's one of the main reasons why our patients do better than other places in the hospital is just that we have better nursing care. There was a great study in the States that looked at what kind of doctor worked best in intensive care. And unfortunately for us, it showed that the biggest thing that made the difference was the number of nurses looking after these patients. Um, so the biggest selling point for ITU is the number of nurses that we have, and it means that we're able to support multiple organs, and we're able to use drugs and therapies that are too dangerous to use in other parts of the hospital. So we'll go into a little bit about what that means in a sec, and then we also work outside of the unit. So we'd be dispatched to other parts of the hospital where we can support patients when they deteriorate. So it's quite exciting in that pretty much wherever the sickest patient is in the hospital, we get to go, and we get to work with them. And sometimes we bring them back to our unit, and sometimes we treat them where they are. So we can support blood pressure. We can put patients on breathing machines and help with their oxygenation. We can put them on kidney machines. We can modify their temperature to help cooling them to protect their brain, or we've got a lot of different therapies and rehab options, tracheostomies and all sorts that we can do. If patients have infectious conditions, as you guys may remember from COVID or things like that, we have isolation facilities. We can stabilize them so that they can be transferred either on land or in the air. And one of the main things again we can do is we can provide time to achieve a goal. So one of the things about ITU is that we're not the cleverest doctor in the room. We can buy time for other specialties. So if you've come across a TV show, Doctor House, uh, where you've got really clever doctors that are excellent at diagnosing really rare conditions, that's not us. But we can keep the patient alive long enough for somebody clever to come along and find the problem. So we have our own specific therapies. We give them time and we support them in a critical illness. Those are the three main things that we do. So who is ITU for? It's a service that's for patients with a potentially reversible condition. So that's something that can be that can be fixed, and that they benefit from closer observation. That's your nursing and more invasive treatment. And generally, what that means is a patient with organ failure. So you can think of any of your particular organs. What would happen if that failed? What would happen if your skin failed, your gut failed, your heart failed, your lungs failed, your brain failed? Any of those failures, pretty much, and you end up coming to ITU sooner or later. So anybody who meets that criteria of having a reversible organ failure comes to us. And sometimes people will refer patients to us if they're not sure and they want a second opinion. What we want ITU to be is a place for that white side of that diagram there for a sick person with a reversible process. What we don't want it to be for is for a person who's already dying, and there's very little we can do about it. And so an awful lot of our training, the reason it takes 10 years post medical school, is to learn to tell the difference between those two groups. So yeah, we'll talk a bit about the ethics, and in order to do that, we need to have a few concepts. So I'm guessing a fair few of you will have been doing science at A level, so this may well be familiar ground for you. But we've got critical illness. There's no agreed definition as to what a critical illness is, but you have organ dysfunction, a high risk of death if you don't treat it, and the potential for reversibility. And then physiological reserve is a really interesting concept that's coming into bear, and it's how much strain your body can take. So you guys have more physiological reserve than I do. You're younger and you're closer to your physiological peak. You guys can be put through an awful lot. I'm sure there's people in your group that wouldn't think anything of going out tomorrow and running a marathon, even though they haven't trained for it. They'd probably be okay. uh, you've got a lot of physiological reserve. You go for some of you may go for a night out, and the next morning you're pretty much okay. Once you get to an older age, you've got less reserve. You can go for a night out, but you'll pay for it, and the next day you'll feel terrible. You guys are at an age where you've got the most physiological age. It tends to peak at around the age of 25, and that's your body's ability to bounce back from stress. And then there's how much work something needs to get done. We talk about the metabolic equivalence of the tasks. That's how much energy it needs to do something. So if you're just lying in bed, that's one met. If you're walking, that's about 5 times as much work as lying in bed. And if you're running at a relatively decent pace, that takes 9.8 mets. Some of you may recognize who that diagram, that picture there is portraying. It's an old Greek person. We don't know what he looked like, but he's running, and he's the first guy to run a marathon. Some of you may know the first guy that ran a marathon survived to the end, and then he died. Uh, so there are things that we can put a person through. I could probably push myself to run a marathon tomorrow. I might die, but I could probably get myself to the finish line, but it might have severe consequences. And then other people, you've probably seen in the news or whatnot, they've trained themselves, they've got more reserve, and they could run a marathon every day and they'd be fine. So it's looking at how much reserve a person has. And that's really important when you think about bringing them to ITU, because the treatments that we give them are very good, they're very intensive, and they put a huge amount of strain on the body. So we need to make sure that the patient has enough reserve to cope with the treatments that we're going to give them. This is a way of assessing how frail somebody is. It's called the clinical frailty score, and it just helps to go through and look at how well somebody is. So there might be somebody who's obviously frail, who never gets out of bed, who feels short of breath if they lie down flat. They're obviously frail, and then at the other end of the spectrum, there's people who are very fit and can run around for hours. One of the things that we're thinking about with that is something called exercise tolerance. And you guys can think about that for yourselves. How much exercise could you tolerate before you started to get stressed? Maybe you could go up one flight of stairs, maybe you could go up 10 flight of stairs, maybe you could climb a mountain and you wouldn't even feel it. How much exercise tolerance do you have? The more tolerance you have, the better a candidate you are for ITU. Once you start to get under strain, your body starts to get a bit stressed. So there's minimal strain. So that's where you might have a little bit of a cold, but you still go to school. You're still doing your classwork. You just feel a bit groggy. You're under minimal strain really. And then there's coping. This is where you've got a headache. Your nose is running. You're really feeling lousy. You probably should have stayed home. You're just about managing, but it's a struggle. And then there's strained compensation. So this is by the time you're still just about managing with your cold, but you're breathing pretty fast. You're having fevers and chills. You're struggling to eat anything. This is strained compensation. And then if it got to the point where you needed to go into hospital, you weren't getting enough oxygen in, your lungs were really struggling. That would be single organ failure. That would be lung failure. And if that got bad enough, once your lungs started to fail, your other organs would start to fail as well. And so you can see how any injury that you get from an infected fingernail, a chest infection, a kidney infection, um, anything can progress from not really bothering you at all to causing severe problems. And so ITU is involved with this sort of the single organ and the multi-organ failures. One of the fantastic bits about medical school, and I really hope you guys enjoy this when you get there, is learning how one system of the body affects the other. If your heart is struggling, how does that affect your kidneys? How does that affect the different systems? And in ITU, we're one of the specialties that really focuses on the relationship between other specialties. Will zoom in on one organ, whereas we're not specialists in any one organ, but we're pretty good at understanding the relationship between the different organs. Um, I'm not sure whether this may be super relevant, but this is a highlight to everyone's course in life. Unfortunately, everybody ends up in the same place. We all die, but the journey we take to get there is different. Some of us will be driving along in a car or something like that, and then we'll have an accident, and then that's a very sudden death. Other people will be fine, and then maybe they'll get an illness which causes quite a quick decline into death. Some people will get worse and then better and then worse and then better, but over time they get bad, and other people will be sick probably all the way through, and then unfortunately they'll pass away. ITU is really looking at working at these blue and purple lines where there's a lot that you can do to reverse it. So if one of you guys or one of somebody's in a car accident, that's a really big injury that might be fatal. But if we can take you to ITU and with the appropriate actions, we can get you back to full health, that's exactly who ITU is for. And that's absolutely brilliant. What ITU probably isn't for is when something's happened and a person's been getting more and more unwell. Unfortunately, they're probably going to die. We can take them to ITU and we can maybe make them die a day or two later. That's not really what ITU's for. We'll skip over that for now. So what we're concerned about is whether a patient has a reversible condition. How can it be fixed, and how much will it cost their body to fix it? Will they be able to get back to work? Will they be independent? Will they be able to get out of hospital? Will they be able to communicate? And we don't make decisions. We're not triaging. We're not deciding that we won't give them that treatment because they wouldn't get the good outcome. What we're trying to figure out is what the patient would want after that. Because if we take somebody who's independent and we put them through ITU, and at the end of ITU they can't walk, they can't talk, they can't communicate, they probably wouldn't be very happy with us. And so we're trying to figure out what a patient would want from ITU. And so ITU is often in this position where we're hoping that we're waiting for patients to get quite sick, but not so sick that we can't save them. That's the dilemma. We don't have a lot of beds in ITU, so we need to wait until patients are really sick, but we don't want to miss the boat and wait until they're too sick. One of the things about ITU, unlike possibly some of the other specialties, is that there's inexhaustible disease combinations. Every day, I've been doing ITU for more than 15 years. Pretty much every day, we come across something that we haven't seen before. So you have to be willing to continue learning, to continue being open, and you don't have the answers. And so you have to learn how to have an approach that helps you choose the best available option, even when you don't have that certainty of knowing that this is the best option. Other specialties will specialize much more. And so it might be that you become the world's leading expert on one particular condition, and you know absolutely everything that the world knows about that one condition. And for some of you, that's going to be the route that you take. And I'm very, very glad that there are people potentially like you who really specialize in and know everything about something. That's fantastic. Um, in ITU, we don't. We know a little bit about everything. And there's so many combinations that you can never know. So how does it look if you guys get through medical school and you become a foundation doctor in ITU? What it would work as a junior doctor, you'd be seeing patients, you'd be doing a full assessment of their entire body, their entire medical history, and you'd be trying to do the basics well. What we know is that the basics are what saves most people, and so our foundation doctors are the ones who are doing the basics, and that's where most of the lives are saved, is by noticing things that other people haven't noticed, and by doing the simple stuff correctly. Um, As you progress to being a registrar, so that's probably year three, four after medical school, you're starting to lead. You're doing more procedures, and there are quite a lot of practical procedures in ITU. You're making more high risk decisions, and then when you become a consultant, things actually change. You might be doing less clinical stuff, but you're doing more of that decision making because in ITU so much is uncertain. Um, you're having to guess a lot of the time. You're having to make educated guesses that you'd be willing to defend. And you're planning, teaching, and you're doing resource allocation. You do a lot of speaking to families, a lot of a lot of quite tricky conversations with people that are in really difficult situations. And then you have to report and evaluate on the decisions and reflect on whether they were the right decisions or in hindsight maybe they were the wrong decision and how you can improve things going forward. So it does change as you go through your medical career. So hopefully for a bit of fun, the medical top trumps in terms of ITU compared to other medical specialties. The pressure in ITU is really quite high. Um, I can't think of many other specialties that are higher. We make a lot of life and death decisions. Most shifts we're making life and death decisions about multiple patients. Um, that is high pressure. Some people that will appeal to, and other people it won't. It's a very uncertain profession in that we often don't know. We're often seeing a patient before they've had any tests, so we don't know what the diagnosis is. And sometimes even after all the tests, you still don't know what the diagnosis is. So there's a high degree of uncertainty. And again, that will appeal to some people because you like being a detective, and it won't appeal to other people where you want to know what you're dealing with. We work a lot of weekends, so that's not great. Um, we don't have a lot of continuity of care. So, like, you'll hear stories of how GPs were looking after patients for 40 years and they got to know them and they got invited to their kids' weddings and all sorts. That doesn't happen with us too much. We don't have, we see patients for a shorter period of time. If you're into private practice, ITU probably isn't for you because private practice in ITU would be far too expensive and nobody could afford us. It costs about £3,000 a day to keep a patient in ITU, and there's not many people that in the UK at least are willing to pay that for private practice. So there's other specialties in the UK that are better if that's of interest. Um, Comfort zone is a big one. One of the great things about ITU and one of the things that drew me to ITU is that because you're used to dealing with sick patients all the time, you're very, very comfortable with sick patients. And there's probably nobody else in the hospital, certainly with adults, possibly even with children, that would be more comfortable dealing with just about anything. I really like the fact that I can pretty much deal with any patient anywhere, and make some sensible decisions. The variety is through the roof. You see everything from children to adults in every specialty. So it is very, very varied. You get a lot of procedures, not as much as a surgeon, but still a lot of procedures. You got to have good communication skills because you're having difficult conversations with a lot of people. You get some nice fancy toys. But unfortunately, your dinner party chat scores fairly low because, as I found, when you're at a social gathering and you tell people they work in intensive care, the room tends to go fairly quiet, and it's not as exciting as, say, yeah, I don't know, being a pediatrician or a brain surgeon or something like that. Most of the time, you tell people you work in ITU, and they go, "Oh yes, I had a relative who died in ITU," and you're like, "Yes." You going anywhere on holiday? So yes, not the best for dinner party chat, but fantastic for comfort zone, for being for the variety that you get to see, for being able to know that you're working with the sickest patients in the hospital, and for applying all the stuff that you learn in medical school, and for having challenging puzzles that you get to solve every day. If that's what appeals to you, it's a great specialty. Cool. So I think that probably takes us close to our time, if not over. Apologies. I will have a look back at the chat and see if there were any questions or pass back to Shruti.
Thank you so much, Dr. Beaton. That was really, really insightful. And it's really helpful to appreciate like the realities of a career in ITU. So thank you very much. For the second part of the session, we'll be moving on into smaller rooms, breakout rooms, where we'll be going through some interview practice questions, based on ITU, of course. So if you could give me just a minute, and I will get the breakout rooms up and Ready. And for those of you that joined during Dr. Beaton's talk, please make sure that you send in the chat your unique identifier number so we can mark your attendance.